Hello and welcome to the second part of the Mood Disorder lecture series. This lecture will emphasize bipolar disorders. The etiology of bipolar disorders is very similar to that of depressive disorders. However, the psychoanalytic perspective provides a little bit more elaboration. Mania is seen as a defense against underlying depression, denial via euphoria. A tyrannical superego produces intolerable self-criticism that is then replaced by euphoric self-satisfaction. According to Abraham, this reflects an inability to tolerate a developmental tragedy such as the loss of a parent. According to Lewin, the manic patient's ego is overwhelmed by pleasurable impulses such as sex, or by feared impulses such as aggression. In essence, mania is a way to deny dependence on objects and simultaneously discover any aggression or obstructiveness that may have contributed to the loss of the loved object. This defense throws off the overly harsh superego. According to the monoamine hypothesis, there's an increase in serotonin, norepinephrine, and/or dopamine in bipolar disorder. According to the monoamine receptor hypothesis, there's an increase in monoamine receptors. Another perspective explains excess glutamate release. Group 2 and 3 presynaptic metabotropic glutamate receptors act as autoreceptors. Agonism of these receptors results in excess glutamate release. Glutamate function involves a very complex process. Glutamate, or GLU, is the master switch or major excitatory neurotransmitter in the central nervous system. This requires glial cells for synthesis. Glutamate enters glial cells via excitatory amino acid transporter, or EAAT. This is then converted to glutamine, or GLN, via glutamine synthase. It's then transported to the glutamate neuron via glutamine transporter, or GLNT, where it's converted to glutamate via glutaminase. This is then stored in a vesicular glutamate transporter, or vGlut. The excitatory amino acid transporter clears excess glutamate from the synapse. vGlut can return glutamate to the synapse. Glutamate can bind to a variety of receptors, but the primary one is N-methyl-D aspartate, or NMDA receptors. In addition to this process, glutamate receptors require co-transmitters in addition to glutamate in order to function. The two co-transmitters associated with this are glycine or D-serine. Glycine is taken up by GLYT1. L-serine is taken up by L-cert-T. These are converted to glycine via serine hydroxymethyltransferase, or SHMT. L-serine is converted to D-serine via serine racemase. Excess glycine or D-serine are destroyed by D-amino acid oxidase, or DAO. Metabotropic glutamate receptors, or MGRs, are linked to G proteins associated with a second messenger system. Groups 2 and 3 are presynaptic and function as autoreceptors. Impaired function of this autoreceptor results in mood instability. When assessing a patient with bipolar disorder, their general behavior may appear excited or hyperactive. They may or may not be grossly disorganized. Their mood and affect is classically euphoric, but can also be irritable, with a low frustration tolerance, and you may see emotional lability. Speech is often rapid or pressured, which can be referred to as flight of ideas. It can be difficult to interpret or incoherent, and it can also be disturbed or distorted. Orientation and memory are usually intact, but these patients may experience delirious mania. Delusions occur in 75% of cases, and they're often mood-congruent manic delusions, such as delusions of grandeur. They have a high degree of self-confidence and are easily distractible. They're cognitively unrestricted and demonstrate accelerated flow of ideas or flight of ideas. Classically, the bipolar patient has poor impulse control, and 75% of these patients can be assaultive or threatening. Impaired judgment is a hallmark characteristic of bipolar disorder, and these patients often have little insight into their illness. The Mood Disorder Questionnaire, or MDQ, is a very good screening tool to rule in or out the diagnosis of bipolar disorder. If the patient answers yes to 7 or more items in question number 1, and answers yes to question number 2, and rates moderate to serious to question number 3, and bipolar spectrum disorder should be considered. This screening tool has a sensitivity of 91% and a specificity of 67%. For the diagnosis of bipolar I disorder, the individual must experience at least one manic and one depressive episode. A manic episode is a persistently elevated, expansive, or irritable mood, an abnormally and persistent increase in goal-directed activity or energy lasting greater than or equal to 1 week, and present for most of the day, nearly every day, with 3 or more manic symptoms. With a depressive episode, there must be 5 or more depressive symptoms for 2 weeks. One symptom must be a depressed mood or loss of interest or pleasure. For the diagnosis of bipolar II disorder, the individual must experience at least one hypomanic and one depressive episode. A hypomanic episode involves an abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased activity or energy lasting greater than 4 consecutive days and present for most of the day, nearly every day, with 3 or more symptoms of mania. In the depressive episode, the individual must experience 5 or more depressive symptoms for 2 weeks. One symptom must be depressed mood or loss of interest or pleasure. In cyclothymic disorder, for at least 2 years or at least 1 year in the child or adolescent, there have been numerous episodes with hypomanic symptoms that do not meet the criteria for a hypomanic episode, and numerous episodes with depressive symptoms that do not meet the criteria for a major depressive episode. During the 2 or 1 year period, the hypomanic and depressive episodes have been present for at least half the time, and the individual has not been without symptoms for greater than 2 months. This is a quick algorithm that shows how medical management decisions are made in terms of managing bipolar disorder. If the patient does not have liver disease, then Depakote is a good option for the patient. Here I've listed the common dosing as well as the max dose. And then on this side, I've shown the Depakote level monitoring. If the patient does have liver disease, then Tegretol is a better option, because Depakote is harder on the liver than Tegretol is. I've listed here also the common dosing as well as the max dose. And over on this side, I've listed monitoring parameters. It's interesting to note that Tegretol will actually decrease antipsychotic blood levels by 40%. If these are ineffective, then usually the consideration is made to add an antipsychotic. This usually results in a 20% higher response. Antipsychotics here are used for acute control as well as long-term stabilization. Often an atypical or second-generation antipsychotic is chosen because there's less EPS. This is especially important in practice if the provider plans to place the patient on lithium, because it can help manage the symptoms of mania while the patient starts lithium, primarily because it takes 5 to 7 days for lithium to become effective. In acute management, 2 really good antipsychotics for the bipolar patient include risperidone and olanzapine. Risperidone may be a better choice if the patient has a history of seizure disorder or is at high risk for seizure activity. For the patient with chronic bipolar disorder and is stable, quetiapine or Seroquel is a better option. This is especially effective if the patient is depressive. Finally, lithium may be added to the regimen. I've listed this here as essentially a third line because of the side effects and monitoring associated with lithium, which we'll discuss. Lithium functions by altering glutamate uptake and release, and blocks the binding of serotonin to its receptors. In the image, I've shown how it blocks the MGR receptor that we discussed whenever we were talking about the biological underpinnings of bipolar disorders. Lithium has an onset of 5 to 7 days. It peaks in 1 to 3 weeks and has a half-life of 18 to 30 hours. In studies, it's been shown to decrease relapse rates by up to 30%. However, it's also shown in studies that it's often discontinued due to adverse events, and this was found to be 3 times higher than with placebos. Suicide attempts and completed suicides occur less in lithium compared with those who did not receive lithium. And finally, lithium was shown to be better than Depakote, olanzapine, and quetiapine in increasing the time to self-harm. Lithium levels range from 1 to 1.5 milliequivalents per liter. The initial level should be about 0.6, and the maintenance level should be about 1.2. The level should be checked at 5 days from initiation, then every 3 to 6 months. I'll add here, while the provider's titrating the medication, it should be checked weekly. It should be checked 12 hours after the evening dose, therefore in the AM prior to the morning dose. Lithium should be avoided in severe kidney disease, severe cardiac disease, severe dehydration, and hyponatremia. Some of the baseline studies include the following. A BUN and creatinine should be checked because of the risk for interstitial nephritis. A sodium level should be checked because of the risk for hyponatremia and the fact that lithium can alter sodium channels. A TSH and T4 should be checked for hypothyroidism. If the patient's greater than 40 years old, an EKG should be done because of sick sinus syndrome, bradycardia, and T-wave flattening or inversion. Finally, urine-specific gravity should be done because of problems associated with nephrogenic diabetes insipidus. Lithium should be used cautiously in the presence of hyponatremia, NSAIDs, and diuretics. NSAIDs can actually increase lithium levels by up to 60% in as little as 7 days. I've listed the side effects of lithium based on the lithium level. At levels less than 1.5, the patient may experience nausea, vomiting, diarrhea, polydipsia, polyuria, lethargy, dysarthria, delirium, memory problems, and tremors. At levels in the range of 1.5 to 2, the patient may experience persistent GI upset, tremor, confusion, hyperirritability of muscles, EKG changes, sedation, and incoordination or ataxia. At levels in the range of 2 to 2.5, the patient may experience ataxia, giddiness, high urinary output, serious EKG changes, fasciculations, tinnitus, blurred vision, tonic-clonic movements, seizure activity, stupor, severe hypotension, coma, and potentially death, usually associated with pulmonary issues. At levels greater than 2.5, symptoms progress rapidly to generalized convulsions, oliguria, and ultimately death. Depakote functions by blocking sodium channels and increasing gamma-aminobutyric acid. Compared with lithium, it has a faster onset, usually within a few days. It also has a higher therapeutic index. A Depakote level should be checked within 1 week of initiation, then at 1 to 2 months, then every 6 to 12 months. The therapeutic Depakote level range for the bipolar patient is 85 to 125 micrograms per milliliter. Compared with lithium, Depakote has a more desirable side effect profile. Some of those side effects may include weight gain, tremor, alopecia, sedation, dizziness, ataxia, headache, nausea and vomiting, and PCOS. Depakote is contraindicated in liver disease, so it's important to look at the liver function test prior to starting. Studies have shown that Depakote decreases the risk of relapse by approximately 30%. It's more effective in preventing depressive recurrences. Depakote has also been shown to be equal to lithium in terms of efficacy, but the side effect profile is much better. Tegretol functions in the same way that Depakote does. However, it's a cytochrome P450 inducer. Therefore, it causes faster metabolism of this drug as well as other drugs, including antipsychotics. Therefore, it can decrease antipsychotic blood levels by up to 40%. Some notable side effects that occur with Tegretol include sedation, dizziness, confusion, headache, blurred vision, ataxia, nausea and vomiting, and benign leukopenia. In terms of monitoring, a CBC should be done every 2 to 4 weeks for 2 months, then every 3 to 6 months. This is primarily due to transient leukopenia, aplastic anemia, and agranulocytosis. A BUN, creatinine, LFTs, as well as a TSH and T4 should be done every 6 to 12 months while on the medication. Sodium should be monitored due to hyponatremia, primarily associated with the syndrome of inappropriate antidiuretic hormone. The therapeutic Tegretol level is 4 to 8 milligrams per liter. Tegretol should be taken with food to decrease GI side effects. It can be taken at bedtime to decrease sedation, and should be used cautiously in renal, hepatic, and cardiac impairment. The last medication we'll discuss is Lamictal. One of the key benefits of this medication is there's no testing required. Side effects that can occur with Lamictal include a rash, sedation, blurred vision, diplopia, headache, ataxia, tremor, and nausea and vomiting. An antihistamine or hydrocortisone cream can be used for the rash. In studies, Lamictal is shown to decrease relapse rates by 16%. In other studies, it's been shown to be equivalent to lithium. However, the side effect profile is much better in Lamictal. Another important thing to know about bipolar disorder management is that there are 2 different types of drugs that should be avoided. Antidepressants can result in destabilization and rapid cycling, and therefore should be avoided in bipolar disorder. And also, the long-term use of benzodiazepine should be avoided because there's an increased risk of recurrence. In terms of psychotherapy, the first line is psychoeducation. The second line includes cognitive behavioral, interpersonal, and family therapy. In studies, it's been shown that there's less relapse in patients using combined psychopharmacology and psychotherapy. In one study, it was shown that the relapse rate is lower with the use of interpersonal therapy and social rhythm versus the control.